we don't typically operate on, very elderly people that have severe kyphosis because that's an age-related degeneration. But what the real reason for that degeneration is actually muscle loss or muscle atrophy. And if you can teach them to use their muscles and do, yoga and core strengthening, we've actually found reversals of kyphosis.
Welcome to the Exercise is Health podcast, where we're talking about exercise, health, and the interconnectedness of the two. We are your hosts, Charlie
and Julie,
and we will be coming to you every single week from our studio, Muscle Activation Schaumburg. Hey, welcome back, everybody, to the Exercise is Health podcast. We are your hosts, Charlie
and Julie,
and we are coming to you from our studio, Muscle Activation Schaumburg in Schaumburg, Illinois. Now, at Muscle Activation Schaumburg, we believe your health is your most valuable asset. Your health is one of the biggest influencers of the quality and quantity of time that you have. And while there are many aspects of health, our expertise is exercise. Exercise has been proven time and again to not only improve your health, but also increase your longevity and improve your quality of life. But we know that exercise is not the only piece of the puzzle. And that is why we are bringing you a phenomenal guest today. None other than Dr. Vivek Mohan. Dr. Mohan is a graduate of the University of Illinois at Chicago College of Medicine, where he also completed his residency in orthopedic surgery. He completed his orthopedic spine surgery fellowship at the University of California, Davis, and the Shriners Hospital for Children of Northern California. Dr. Mohan received board exposure to spinal surgery, from minimally invasive spinal fusion surgery to complex anterior and posterior spinal fusions for spinal deformities. He also had the opportunity to treat children with complex congenital, neuromuscular, and idiopathic deformities at the Shriners Hospital for Children of Northern California. Dr. Mohan is board certified in orthopedic spinal surgery. He is trained in and has performed all aspects of orthopedic spinal surgery, from minimally invasive surgery to the treatment of complex deformities and metastatic tumors in adults and children. His medical interests include cervical, thoracic, and lumbar spine surgery. He takes a conservative and multimodal approach in addressing each patient's spinal conditions. He is affiliated with Immediate Health St. Alexis Hospital in Hoffman Estates and St. Joseph's Hospital in Chicago, as well as 900 North Michigan Surgical Center. Dr. Mohan, thank you so much for joining us and welcome to our show.
It's a pleasure to be here. Thank you.
Absolutely. So tell us more. How did you get into medicine to begin with? How did you start to focus on the spine? And how did your interest in working with both adults and children for spinal conditions come about?
So I was always mechanically inclined. I actually was an engineering student in college.
Wow.
And then I found sitting at a table not to be my passion. So I decided to go into medicine to do more reconstructive type work. As soon as I saw hip replacement surgery, I fell in love with orthopedics.
Oh, cool.
And that was in medical school. And then in residency, I exposed myself to everything from hips to hand surgery to spine surgery. Mm-hmm. And then we were exposed to spinal surgery for kids and scoliosis. Mm-hmm. And that was really what attracted me to spine surgery. Wow. Fixing deformities, going from a very curved spine to a straight spine the same day. Very impressive. And then these kids would just go back to doing normal things after a couple of weeks.
That's amazing.
And that's why I got involved in the spine surgery. But today, my practice, I do everything. Mm-hmm. And pediatric spine surgery and scoliosis is a small portion of it. But it's still a fun aspect of what I do.
That's wonderful.
So one thing you said that I thought was really interesting that is really vibes with how Charlie and I operate here is that you were an engineer, and then, which in my brain is, I'm thinking like structures and like figuring out how things function, but then you kind of are like an engineer for the bones now.
Correct.
It's really fascinating.
Is, yes.
It actually, yeah, it really is. And because we kind of think engineering and physics as how it applies to exercise, because obviously we're not going inside the body, but we're trying to figure out, okay, well, what is like the landscape of this surface or this joint, and how can we manipulate exercise to that? So I just thought that was really cool, and I was like, oh my gosh, you're like the surgeon version of our training protocols.
And actually in orthopedic residency, there's a lot of engineering principles we have to learn. Sure. Materials, because we put implants in, we have to understand corrosion and, forces, dynamics. Those are things that are very important. And as time has gone on in the last 15 years, engineering is actually more involved in orthopedics than ever before.
Sure.
As it should be.
Yeah,
for sure.
Absolutely. So what are along those lines, kind of what are some of the advances that you've seen, since you've been practicing as far as what's happening with spinal surgeries, is from the materials used to the thought process behind it. Can you speak to that?
Yeah. So when spinal surgery began with implants back in the 80s, actually, it was a variety of materials, and I don't believe that the science was ready for that yet. It was a learning curve that we hadn't reached yet. It was just the beginning. But now we've advanced it. We have very specific titanium and titanium alloys that we use. We've understood materials enough to know which materials work well together. And also we have to understand bone biology, what bone likes to attach to.
Sure. Because
in most spinal surgery, we're fusing the spine. And in doing so, you have to have structures that'll hold the bones together while it's healing. And in doing so, you need good properties. So titanium seems to be the best metal out there because bones seem to adapt to it. And also it's soft enough where it's not causing bones to break around it.
Oh wow!
Interesting.
Like there could be material that might be stronger than a bone or something, so then the bone would break versus the material.
Exactly. So there is some like plates, and you do orthopedic fracture repair. You tend to use stainless steel because it's stronger than bone, and then you put them in a cast, and once it's healed, then the plate's not doing anything anymore. So typically we use plates for those stainless steel plates for those reasons because you want to hold the bone very stiff for a period of time until it's healed.
Sure.
Therefore, titanium won't work for that because it'll bend. It's malleable.
It's too flexible.
It's too flexible. Not something that you and I could bend with our hands.
Sure.
But the forces in the body, 100 pounds standing on it, could bend it.
Sure.
Yeah. That's really interesting. Again, something that you're validifying what we kind of talk to our clients about is we talk to them about, they're like, oh, we're only doing 5 pounds. Like they're holding a 5-pound dumbbell. But I'm like, but the internal forces on that shoulder that you're having trouble with or that knee that you're having trouble with are really high. So this is where we have to be right now. So that's really interesting that you guys get to see that. I mean, that's
I emphasize that every day as well to patients who either have issues in their back or have recovering from surgery, how to keep their posture, how not to lift stuff, how to lift stuff properly. People returning back from a work injury, to squat and not to lean forward because the lever arm on the back at the hips is worse for their back muscles. And that's how people get strains and sprains in their back from improper use of their muscles.
For sure.
Wow.
So all those are very applicable and something that you guys discuss with your patients too.
Yeah. Well, it's just, as we just started this conversation, it's interesting to hear the piece that you get to see all the time that we kind of talk in theory about, because we don't get to, open people up and see, what's going on. Unfortunately. So tell us a little bit more about your practice. What kinds of things do you guys deal with? What kind of things do you treat?
So for the most part, my practice primarily with adults, because again, adults have more problems than kids for the most part. But I treat everything. So treat from herniated discs to neck pain and stenosis, which is a very common problem in the spine, to fractures, which is less common. So all the conditions, but most again are degenerative in nature, right? So as we get of an older population, we tend to get more back and orthopedic problems.
So talk to us about the different problems that you see. And I know that kind of in your intro, you brought up like scoliosis and working with all populations with that from kids to adults. So you can talk to us. All right, first of all, I guess let's start at the very beginning. Like, what is scoliosis, and really what's the issue with scoliosis?
So scoliosis in general is defined by curvature of the spine. And when they say curvature, it's not the curvature from the side, but typically we're talking about the curvature from when we look at them straight on. So when we take an x-ray and we're looking at it from the front or an anterior posterior x-ray, the curvature in that plane, we call that the coronal plane, on face. And that's not typically normal, especially if it's over 10 degrees. Anything over 10 degrees gets the diagnosis of scoliosis. Typically it's straight. And then you have to classify the scoliosis. Is it congenital, meaning from birth? Is it juvenile or adolescent, meaning that it started at a young age? Okay. And then is it idiopathic. Idiopathic means, well, we don't know, but idiopathic typically means genetic, meaning is it something from childhood or from previous generations that had been present. If a lot of moms have scoliosis, their kids would have scoliosis, a very good predisposition for it.
Oh, really?
Interesting.
I've seen many kids whose moms or dads or actually aunts or grandmothers have had scoliosis. So scoliosis in kids is a 2-to-1 ratio female to male.
Wow.
So there's more common in women or girls
2-to-1,
than
I
in men or boys. And that's in pediatric scoliosis. So the pediatric scoliosis is an abnormal curvature of the spine that often happens due to an irregular brain muscle development.
Okay.
So the brain signals the muscles to grow in a certain way, and then the curvature forms. So that's the genetic predisposition. If we catch it early on, or in the stages where we can try to prevent the progression, we try different methods, whether it's certain therapy methods and manipulations. Bracing is very important, especially in the mid-range, anything over 20 degrees. And if there's still growth remaining, we try to brace them to minimize their growth. But after 45, 50 degrees, then we consider surgical intervention.
Okay. And so when you say bracing, is it something that's worn around the thorax, or what do you mean by that?
Yes. So the brace is a hard shell. The shell can be removed on and off during the day, and it's worn throughout the day, and it's supposed to reposition the spine within the brace to a better allotted position. And then as the kid grows and also the curve gets better or worse, we try to modify the brace as needed.
Gotcha.
So, girls tend to, form hips and breasts, and we have to adapt the brace for that region. And also, boys tend to grow quickly. Their brace tends to get short. You need to get them. And boys can grow up till they're 18 or 19 years old sometimes. And so the bracing goes on till they're done growing.
Okay.
Yeah. You mentioned, if you catch it early, you're able to brace, and if it's in that mid-range of 20 degrees. What does early mean? Does that mean like when they're toddlers, or what does that mean?
Early is more about the curvature. Okay. Early is the curvature. So if you catch the curvature within the 20 to 30 degree range, and there's still growth remaining of the child, right? So that's the key component. If you have a 20 to 30 degree curvature in a child that's, I guess, say 19 or 20-year-old child or adult, they don't need a bracing because they're done growing.
Oh, like there wouldn't be as much adapting going on because they're not growing anymore.
No, there's no more growth. So we compare it to a tree, and that's actually why the orthopedic emblem is a tree that's curved with the stick holding it up, so it keeps it from falling. That's actually a pretty famous orthopedic emblem. Because if the tree is curving, we can kind of prop it or brace it. So while it's growing, we can recorrect the curvature, redirect the growth. If they have a very low curvature, like less than 20 degrees, 10, 15 degrees, there's not enough curvature to brace. You can't overpress it or curve it the other direction to change the growth. It's too early.
Okay.
Or if they're already done growing, there's no point, right? Or if it's over 50 degrees, then it's so high that the bracing is actually at that point ineffective because gravity itself is going to continue to keep working on the curve and pull it down.
Sure.
So if you can imagine 45 degrees being like that, the gravity is going to keep pulling it over.
I can see that.
Over time. And usually that's why we recommend over 50 degrees, especially if there's growth remaining, we should definitely fix it with surgery.
Okay. So if somebody comes in and they have a curvature that's less than 20 degrees, you said bracing's not an option because it's not severe enough at that point?
Correct. It's not large enough to necessitate bracing.
So then do you just have to say, well, okay, we have to wait until you get worse? Or what's kind of done with that? Because you were saying earlier that like 10 degrees is kind of the initial indicator of scoliosis or the initial diagnosis level of scoliosis. So there seems to be that gap between 10 and 20. What is often done in that range?
So under 20 degrees, we have a discussion with the family and the patient regarding options. So if they don't have back pain, which is a very, very common finding in scoliosis in children, we tell them, okay, be active, do exercises. And I do refer them to therapists and chiropractors that do manipulations called the Schroth method. And the Schroth method has been shown to have some benefit in patients with mild to moderate curves or curves that, or in children that have already done growing, they want to just maybe improve their curvature a little bit through modulation.
Gotcha.
And it does seem to help. It does seem to
wonderful.
help. It's not going to fix a 60-degree curve.
Sure.
And it's not going to make a 10-degree curve go to zero. That's not the goal of it. It's really just to maybe mitigate or slow down any growth. And then even in the 20 to 40-degree range, when I am bracing, I do also recommend this manipulation because it has some added benefit. Again, through muscle activation and brain pathways to help correct the curve, redirect the curve.
So does it, if somebody is done growing, is that still an effective kind of process for them to go through? Or at that point, is there not much change that's likely to happen?
So newer studies have actually shown that if you've all seen the older people hunch down, we call that kyphosis. You know, when they, as they get older, they kind of lean forward and end up looking at the floor. We don't typically operate on very elderly people that have severe kyphosis because that's an age-related degeneration. But what the real reason for that degeneration is actually muscle loss or muscle atrophy. And if you can teach them to use their muscles and do, yoga and core strengthening, we've actually found reversals of kyphosis.
Wow.
You may not change their scoliosis as much,
Sure.
but people can tolerate scoliosis curves in that frontal plane or the coronal plane very well. That usually doesn't cause them pain.
Okay.
It's the kyphosis that causes significant quality of life issues.
Gotcha.
And that's what I try to emphasize with therapy and with muscles and strengthening.
Okay.
Yeah. That's really, really interesting that there's a couple things that, the body can really handle the scoliosis curve a lot better than that kyphotic curve. But, when you were saying that, what was it called? The
Idiopathic
scoliosis, which is, you said, was more of the genetic one. And it's kind of like the brain communication to the muscles. I've never heard that before. That's really, really interesting. And is it just the brain is developing the muscles unevenly as a child develops, or what's going on with that? Or is it still kind of unclear?
So we're getting better idea. I don't think it's 100% clear cut. It's a brain to muscle activation. And if you understand that kids, most of their growth happens at night when they're sleeping, right? And so initially we had theories that, kids who sleep on their side and they get curves and all that stuff, but that's not validated. The most important thing is that it's a brain growth pathway. The brain tells the body to grow through hormonal and signaling pathways. So the brain signals the muscles to pull in certain locations, and that's how bones grow and other surrounding tissues grow. There's actually good data. This is an example of how the brain signals. If you spend a lot of time on monkey bars as a child, you tend to get longer arms, and it tends to grow. There's actually
That's awesome.
There's good data that's how the growth is pushed because your body is getting signals from the joints and from the bone, from the physes, we call it.
That's so funny. So I'm thinking back to a video I used to watch all the time as a kid. It was a Michael Jordan highlight reel. It's called Michael Jordan Come Fly With Me. And and it was talking about his upbringing, his childhood. And, he's 6'6", and the rest of his family is really short. And so the person on camera was asking, well, how'd you get so tall? And he said, actually, I saw an episode of the Brady Bunch where they were hanging from the monkey bars. He goes, I used to do that all the time. I used to go out to the monkey bars and just hang, thinking it would make me taller. So that's so funny.
I don't know if I'm going from 5'8" to 6'6"
Sure,
to make a difference, but maybe like an inch or two.
That's pretty
maybe.
hilarious.
Yeah.
So funny.
That's really funny. So so talk to me then about what's the issue with having scoliosis? And if, somebody comes in and they're relatively young or they're asymptomatic and they have, maybe they have a 10 degree, maybe they have a 20 degree, but, they seem to be able to do everything that they want to do. What's the issue either in the short term or long term for somebody that has this scoliotic curve?
Well, again, let's go back to the classification scheme first. The idiopathic scoliosis, the one from childhood typically, it usually doesn't progress once they're done growing. The curves that are in the middle range, that 20 to 30 degrees, people usually tolerate those very well into adulthood, and they can live with that. It's not an issue. Occasionally, some people will get problems as an adult, and we try to address it where we can. Then you get adult-related spine problems like disc degeneration, herniated discs, and we treat those independently. In children, they grow up and they're fine. Okay. I don't worry about them, especially if they didn't have surgery. Mm-hmm. If their curves are much higher and you don't treat them as a child, so let's say at 60 or 70 degrees, they don't typically even still have pain. Mm-hmm. But at 70 degrees, they'll start noticing they can't run. They're exhausted. Oh. Their lungs are getting limited expansion.
Oh, sure.
And if you go really high, you can get abdominal compression as well. And then they can't eat as much. They start to lose weight.
Sure.
And I've seen those cases as well. Mm-hmm. And then there's the whole cosmetic aspect of it. Being a teenager, especially a girl, it's very disastrous in all psychological perspective as well. And then those patients you have to fix if you want them to have significant quality of life improvements. Mm-hmm. And the other aspect of it we didn't talk about yet is the degenerative type. So patients in their 50s, 60s, and 70s, they don't get the scoliosis as genetic in the sense that we know about the brain muscle development, but theirs is where the degenerative disc disease and the joints wear out, and it causes their spine to start curving. And typically they get a little bit of back pain and soreness, but if it doesn't cause any compression of their nerves, they're usually fine.
Sure.
Yeah.
If they have associated problems like instability, where they get we call it spondylolisthesis, that's a front to back instability, that causes back pain, and that's somewhat also poorly tolerated. Those then we have to treat like an adult back problem. We try physical therapy, we try conservative methods, maybe even injections. Bracing doesn't really work for that population because you want their muscles to be active. You don't want to brace too long. You could do temporary bracing for activities, but otherwise you really want them to be as active as possible.
Gotcha.
So those are the two categories, but degenerative we tend to not necessarily have to fix unless it's very severe, like over 25 degrees typically.
Okay.
And what is the degenerative type scoliosis caused by? Is it just joints wearing out, so then they're wearing oddly or not as symmetrically, and then it just grows and grows and grows? Or is it from being sedentary and just their muscles are weaker and they can't support their spine? Those are the hypotheses I have in my brain. But what do you guys see? And again, you can't ever know what causes exactly, but what are you hypothesizing that could be causing this degenerative style of scoliosis?
So the degenerative style of scoliosis is usually due also to a genetic component, but because it arises from wear and tear of the joints and the discs, that's somewhat programmed by the body at certain levels. Like certain discs wear out, certain joints wear out. It's like a car, right? Why does some cars wear out faster than other cars? Some of it's also utilization, right? So what you did to your body over the last 6 years ends up showing up later in life. So if you did a heavy labor-intensive job for 50 years, the wear and tear is there. I've seen postal workers where certain aspects of their body are worn out from the heavy lifting. And I've seen construction workers who have a normal back. So everything is variable. But part of it is genetic and then the use component. So it's unpredictable what caused it, but progression is variable as well. And we try to treat not necessarily the structural component, but the nerve component. If the nerve components are really what deteriorates patients' quality of life more than just the arthritis and the disc degeneration.
Like if the nerves are compressed?
Correct.
Okay.
Correct. Nerve pain, stenosis, where the nerves are getting compressed, and then that instability.
Okay.
That's an instability, and that often causes significant loss of ability to do your daily activities.
Sure. Are you seeing any trends or changes in the frequency of scoliosis diagnoses coming up? Whether it's, with kids and with any relation to technology use, or with adults and, sitting funny or anything like that?
So scoliosis, no. I think scoliosis is purely diagnosed by the teachers in school or the nurses at school and kids, and then often they send to the pediatricians or spine specialists. And adults, again, the scoliosis is determined by an x-ray. I don't think the frequency of scoliosis has increased. What I am seeing is more of a poor muscular activation form of kyphosis.
Okay.
That we talked earlier.
Sure.
Again, kyphosis, we in the spine world we call life is a kyphosing process, meaning as you get older, you tend to move forward.
Exactly.
And it's hard to visualize over the radio here, but it's a visually, if you watch yourself, as a child, you're standing up straight, and as you get older, you tend to lean forward, and you can just see yourself. And all my older patients say, hey, I've lost height in the last 10 years, and that's due to that kyphosing process. It's the discs wearing out, the muscles just getting weaker in the back. And as long as you actively try to use those back muscles and your core, you could limit that kyphosing process. And it's very good for your overall health. But that's what I see in the texting world and the computer world, and everyone's sitting at a desk for 8 hours a day. And unfortunately, they've actually shown that the decrease in length of life from people who have worked 8 hours a day at a desk.
Really?
Wow.
Yeah.
Wow.
So if you just sit at a desk for 8 hours a day and don't get up and don't have other forms of active exercise outside of work, there's a decreased length of life.
Yeah.
It's pretty scary.
So I have two questions now that you brought that up. With this chronic kyphosis that just kind of builds over time, and I'm going to pair it with the degenerative scoliosis, are these just the way that the muscles are holding the bones of the spine, or are these actual, like, the bone has now changed shape, so now you have to stay there in those positions? Does that make sense? Is it like the structure of the bone that's different, or is it just how well the muscles are doing at holding up the spine or holding up the structure?
So there's two components. So number one, during normal course of life, especially women in menopause, they can get fractures.
Okay.
Some can get subtle fractures that happen through mild trauma, like even lifting boxes, versus others get into car accidents or have falls and they get a fracture. And then that causes the initial incident of kyphosis. Okay. And then that initial kyphosis then continues on throughout life, and unless you do something to compensate for it, it can progress. So that I guess leads to one aspect. But the second aspect is the bone. So let's say there was no inciting event, and let's say you're pretty active. If what causing that kyphosis or scoliosis is oftentimes the joints wearing out. It's not the bones themselves, it's the joints. And the joints cause that subsequent loss of proper alignment.
I see.
And then once the joints wear out, the discs tend to wear out because they're overloaded or they've biochemically worn out.
Sure.
And so those are the processes that lead to the degenerative type of scoliosis.
I see. And with these joints wearing out, I know that everyone is different, kind of like the example you gave with like the cars. Like one car wears out faster and you can't always know why. But are there lifestyle factors that people could control that might prevent, the premature wearing of their joints, if they could do anything about it?
You can't necessarily prevent your back wearing out in a certain way. Like some people just get hip arthritis and need a hip replacement by the time they're 50 or 60. But there are certain factors that you can definitely help with it. Smoking is a known cause of discs to wear out faster. That's a known cause, and I explain that to everyone. They're always surprised by it as well.
Yeah.
So every patient that has bad discs, I always ask about smoking, and especially if you're young, because then I tell them that's going to progress. The chance of getting more herniated discs or disc degeneration is increased in smokers. Obesity by itself does not cause degeneration of the discs or back pain. It's the inactivity that's often associated with being obese that leads to back pain and muscular back pain. But those patients who are obese also get the back problems that I've talked about above, the scoliosis, the spinalolisthesis, and those are the conditions that I often treat surgically if it gets to that point. The obesity didn't lead to that, so it's not related, but the outcomes are correlated to the weight and the smoking and all that stuff. But the whole the component that we don't talk about is activities, right? Whether you're, a triathlete in your 40s and 50s, or whether you're sedentary in the office all day, does that lead to having a spinal problem later in life? And I don't think they're correlated necessarily.
Okay.
Being active is good. Oddly enough, certain activities can increase your rate of back problems, and it's often, people who do a lot of deadlifting, like Olympic deadlifting. Those guys are lifting hundreds of pounds, and that's dangerous for your lower back. That can lead usually to recurrent herniated discs. But most activities shouldn't. Being active is an important part. Most activities don't lead to accelerated back problems.
Gotcha. So talk to us then about the spinal surgery part of your practice, okay? What would make somebody a candidate for surgery? You were talking earlier, hey, if the curvature is 50 degrees or more, that would make them a candidate for spinal surgery for scoliosis. But there are other surgeries that you perform for the spine. So what would be somebody's reasoning for going and seeing a spinal surgeon?
So regarding the scoliosis in kids, we do our best to minimize their curve growth and watch it over time. If they do hit 50 degrees and have a potential of growth left, we always have a discussion with the parents and the child and tell them that surgery is indicated at this time and we're doing it to prevent progression. And they're usually very on board and they understand because this curvature is pretty significant. Outside of the scoliosis realm in adults, the most common surgery we deal with is laminectomies and fusions. And the reason we see surgical pain is nerve-related pain oftentimes, pain going into the arm or going into the leg. And for the lower back, the instability is the most common reason we do fusion. So spondylolisthesis, where mostly do it at the L4, L5 level, where they're shifting while the patient is walking or standing, and then it causes pain going down their leg.
Yeah.
And that's usually when they end up coming to me because now they got a leg pain. Most people, if they just have a mild amount of instability and it doesn't cause leg pain, they usually live with it and they can tolerate it. But once the nerve pain hits, that's when it's a significant issue. And that's when I operate. So the number one reason people end up seeing me is nerve pain, nerve-related pain, numbness, tingling, weakness. And if they don't have significant nerve damage like weakness or prolonged sensory loss, then we can try conservative treatments such as therapies, injections, medications. But once they start getting the unrelenting pain over 3 months, weakness, and then if it gets very severe, if they get balance issues or dexterity issues, then we have to operate sooner.
Okay. So that's kind of criteria then is, hey, if somebody's had leg pain for, that's unrelenting more than 3 months and they are starting to possibly suffer some weakness associated with it, possibly some balance issues or whatnot, then that's definitely a sign that, hey, they need to contact you, they need to schedule you, or that they should go and find a spine surgeon in their area.
Correct.
Okay.
So that's the indication is for a consultation at least and have a discussion. And there's a lot of causes for weakness. I've seen people come into my office and they really had a stroke, as opposed to a spinal problem, right?
Sure.
Or other people have multiple sclerosis, and this is just an early finding, of weakness or numbness.
Sure.
So you have to identify the problem, obviously. But yeah, so those are the indications to see a spinal specialist and maybe a surgeon.
Sure. Yeah. Number one, I have to comment. I didn't realize how much of this nerve pain that you would have dealt with. That's not what comes to my mind when I think orthopedic spine surgeon. And I'm sure most of the people listening are like, oh, I didn't think of that either. But what is it like when someone were to schedule with you a spine, orthopedic spine surgeon? What is it like? They schedule, and then when they walk in, what are you doing with them? What are you doing to examine them or discover what's going on?
So most important thing is have a discussion, right? Listen to the patient, hear what they have to say, what are their complaints, spend at least 5 to 10 minutes just hearing them out of what their issues are. Whether it's walking, weakness, and pain, we assess all of that. And then the causation. Listening really, just those few minutes gives you so much insight into their condition that you can almost tell before you even get to the images what's going on with them. Then you do a thorough exam. And if you do a very standardized exam, you can identify the source of the problem relatively quickly. And then you compare that and correlate with the images, X-rays, MRIs, and maybe CT scan. So those are the key findings.
I see.
And then we have a treatment plan. Then we have to decide what to do next. If it's physical therapy or if it's more invasive and you have to do a surgery due to some significant issue.
I see.
And when you're doing a surgery for somebody and you're doing a fusion type surgery, is that where you are inserting the rods, or what is happening with a spinal fusion surgery?
So the goal of a fusion is to, one of two things. Is it to correct an instability or a scoliosis, and where we're correcting a deformity, right? A spondylolisthesis, or that instability, is really a low-grade or mild instability or deformity, right? A scoliosis being 50 degrees, that's a huge deformity. That's also a form of a deformity. And the screws and rods are just aiding us in that healing process. So once the bones heal together, the rods and the screws don't make a difference anymore. Okay. So technically their purpose is done. So but we put in the screws and rods to correct that deformity, to stabilize it in the right position, that we'll be satisfied with it, and then the bones will grow around it to eventually put those two bones together and stabilize it so it doesn't move anymore.
Okay.
So when people have rods in their spine, it was there for an initial purpose, and then it would just probably be more invasive to have to surgically go in and then remove them once they're not really serving a purpose. I see.
Most people don't need it removed. It's not bothering them enough to have it removed. Very few people need it removed.
I see. Okay. I had ankle surgery when I was like a freshman in college, and it was a similar thing where they had to insert some hardware. And I was like, so when are you going to take it out? Because I thought, well, why would I have a screw in my ankle? And they're like, well, we don't really actually have to because the bone is healed all the way around it. And I thought, oh, okay, it makes sense.
Exactly. Everything heals around it, and it's not serving a purpose as long as it's healed.
So when someone's like, I have rods in my spine, that's what they say, that means they've had a spinal fusion. That's the same thing? Or is it
most likely?
Okay.
Most likely. There's a small percentage of people that have instrumentation in their back when they didn't have a fusion. It could have been a fracture that had to be repaired, or if they're a child, there's a newer technology for scoliosis in very young kids, so kids under the age of 10, and there's still a lot of growth left. They don't want to fuse kids under the age of 10 because they still have to grow. The newer technology is actually growing rods, so they grow with the kid.
Cool.
Oh, interesting.
And the really cool thing is that now in the last 4 to 5 years, we've had rods that are magnetically adjustable. So we put them in, and then in 3 months, we grow them while they're in the patient. We put a magnet over them, and then they can grow.
Wow.
That's cool.
That's really cool.
Yeah. And so we don't have to change them every 6 months, surgically change them every 6 months like we used to. Wow. And now these are done maybe every 3-4 years.
Yeah. Okay.
So they can grow a certain length. Yeah.
Now, what are the pros and cons of having these rods in your spine to spinal fuse or to correct a scoliosis or something like that?
Well, they significantly increased the fusion rate. So before the 80s, when these procedures were done, the fusions wouldn't heal very quickly and would also require a lot of bracing for 6 to 8 months.
Wow.
And people were limited in their activities for a long time. I mean, when they first did them in kids in the 40s and 50s, 80 years ago, they keep them in bed for 6 weeks.
Wow.
4 to 6 weeks, and then in a cast too. So it was a long time. So the screws and rods now, I mean, once you correct the deformity and you put bone over it and eventually it'll heal, you can get up and start walking the same day. You can get out of the hospital in a few days and go back to school. You just can't do any heavy activities for a few months, but it's amazing recovery. And that's the advantage of the implants. It really has improved the healing rate to over 90%.
Wow.
So before that, it was roughly 50%.
Wow.
That's incredible. What about in older adults? Say if somebody is, 50, 60 plus, and they're going to have a spinal fusion, what does that look like, and what's the kind of return to normal activity rate like?
So that's probably my most common patient. Is a 50 or 60-year-old, sometimes early 70s, and they have a one-level spondylolisthesis at L4-5, needs a one-level fusion. We can typically do it minimally invasive nowadays with 2 little incisions about 3 centimeters each. We don't remove any muscles. We just kind of separate the muscles apart for a few minutes, but an hour and a half. And we perform what we need to do. We put the screws in. And as long as their bone density is relatively good, we use them. The screws will stay in. And unless there's any issues with the incision or the screws are loose, we don't take them out.
So they're in there indefinitely, and the patients seem to be recovering really well with the minimally invasive. And
yes, so the typical time frame of recovery for a one-level lumbar fusion, probably the most common fusion across the country, is 3 months with no bending or lifting.
Okay.
But then after 6 months, we let them play golf.
Oh wow, nice.
So
golf is about as extreme as you can get for your spine.
It's like all the way bent and all the way twisting.
Yeah.
Of course.
Yeah, because you have to bend to pick up the ball.
Yeah.
And you have to swing, a club that's, now you're trying to hit a ball.
Multiple times.
Oh my gosh. When people tell me how frequently they golf, I can't help but think to myself.
You're like, I don't do much. I just golf 3 times a week.
I'm like, there's few things you could do that are possibly more stressful to your spine from a motion perspective.
Yeah.
Not from a load perspective, but from a motion perspective.
That's the funny part is so that I see people golf a lot, and especially physicians and, a lot of professionals like to golf, but yet their core is not strong. And that's a high risk factor for back problems. It's just that combination is just bad. And then you can smoke on the golf course. It just adds another whole layer of medical issues.
Right.
We find so often that when our golfers start coming in, we have to see people when they're still cleared for exercise. They don't need physical therapy, but they're like, I just feel like if I got stronger and, I could hit the ball better, they just do so much better on the golf course and other areas too. But, golfers, 90% of their day, they think about golfing. So it's like, I hit better, my motion's better. It's like crazy how much the muscle system can feed into how that structure's moving.
And actually even pitching, a lot of young pitchers, they tend to throw it from their arm.
Sure.
And as you get taught by good pitching coaches, they tell you it's really in your legs and your core.
Yeah.
And if you watch Sandy Koufax from back in the day, you see that guy, he was like really twisting his whole body to throw a pitch. So that's kind of the key way of limiting rotator cuff tears and elbow injuries is really by using your core and your leg muscles in pitching. And so there's a lot of twisting sports that require a much more core strength than we realize.
Sure. Well, that's really cool that, even after a surgery, like getting some kind of spinal fusion, whether it's minimally invasive or not, that, within 6 months, people can be back to doing those twisting type activities. That's really neat. I think to me, it just speaks to how far the technology and the techniques have come from a surgical perspective. So that's really cool. What are some indicators that somebody might have a spondylolisthesis? If they're like, what are some things? Is it something where, hey, it's just some back pain that they're feeling or some back tightness, or are there other indicators that would tell them, hey, you know what, this might be a little bit more serious. Maybe I should schedule a consultation, get this checked out.
So the most important thing is actually with spondylolisthesis is back pain with prolonged standing, but also what we call is claudication. Claudication is a term we use, is basically a problem with distance walking. So what happens is like you walk a certain distance and then you have to sit down because you get back pain. And then you sit for a few minutes and then you can walk again. So we call that claudication. And there's two types of claudication. There's neurogenic claudication, so it's a nerve problem. It's in the back. It's compression. So there's stenosis with or without instability. And then there's vascular claudication. So people who have blood vessel disease, if there's not enough blood flow into the feet, they also have claudication. It's very similar. So you have to make sure you rule out the blood vessel disease.
Sure.
Usually in those patients, it's more of a overall health issue that you can visually see that, their legs are swollen, they're not healthy, they often are smokers, and they have heart disease. So those patients you can clearly see. But neurogenic claudication, where the nerves are getting compressed, as they walk, they can't walk long distances. And then as time goes on, it gets worse. That's usually a sign that this is a back problem
Sure.
that needs to see a specialist.
Okay.
I thought you were going to say there's two kinds, the orthopedic kind and then the pregnancy-induced kind. 'Cause I remember when I was pregnant, it was like, oh my gosh. When I was 9 months pregnant, I think because of all that anterior weight, you're like walking. Anyways, side note.
Luckily, pregnancy is a time-related problem, and
you
usually
eventually
gets
are
better.
done with it.
Exactly.
Yeah.
It leaves some remnants, but for the most part, you're done with it.
Sure.
Yes.
So, Dr. Mohan, you've been educating us, you've been educating our audience about some things that might be indications that we're having issues with our spine, about things we can do to help kind of protect our spine and, keep our spines healthy overall. But I'm curious, what do you do on a daily and weekly basis to kind of help promote and improve your own health?
So it's a good question. And actually, this is an interesting story. So I'd love to play sports, and growing up, I played a lot of sports: football, basketball, tennis, different things. And I was relatively healthy for most of it until I hit residency, and I didn't have time really. I just maybe exercised once or twice a week. And then as I went to fellowship, I was working 12-hour days, and I would come home, and I would have back and foot pain because I was just standing all day.
Wow.
I was standing in the operating room, bent over, doing all these major scoliosis surgeries 2 to 3 times a week, and I was getting back pain. And I said, "This is not right. Something's wrong." And my wife at the time had said, "Why don't you try yoga?" So I'd never tried yoga, and so we went. She had been starting doing it, and so I went and started it. And within 3 weeks, my back pain went away, my foot pain went away.
Awesome.
And really what it was is core activation, right?
Yeah.
I had none. I had not been using it. And so that really led me to the process of realizing that I need to be more active.
Awesome.
And then I reached a point where yoga was great, but I wasn't really, overall my cardio wasn't there. So I included a cardio part of it. Now what I do is I do cardio with yoga. And it's an excellent form of exercise, at least 2 to 3 times a week.
I love it.
Great.
I love it. What's your cardio of choice? Are you running, biking, swimming, elliptical?
Well, currently it's actually like a yoga sculpt class.
Oh, that's cool. So it's like a yoga class, but like faster movement involved?
Yes,
Oh,
faster movement, some weights.
Neat.
Awesome.
It's all body parts, a lot of squats, unfortunately, so it's tough.
Well, it's amazing because we always talk to our clients, especially when people have orthopedic issues and they can't be doing, 10,000 reps of stepping every day and running. And, we tell them, hey, you can get a huge cardio benefit from not doing like the traditional cardio type exercises. Like we can structure your weight training or, your activities so that they can get your heart rate up and you can still get that cardio benefit. So I love that you brought that up.
Yeah, so I modified the activities. Even in the class, they tended to do a lot of overhead lifting. I don't do any of that because actually, as I get older and as a lot of people get older, they get rotator cuff problems. And you don't need to do a lot of overhead lifting, and it aggravates my shoulders if you do that.
Sure. No, it definitely makes sense. It definitely makes sense. So if one of our listeners is thinking, hey, you know what, I'm having some unrelenting pain, or, I notice that when I walk for long distances that I need to sit down because my back's bugging me, or if I stand for a long time, essentially, if our discussion is kind of triggering in one of our listeners' heads that, hey, you know what, maybe I need to see Dr. Mohan, how would somebody get in contact with you?
So one of two ways. You can always call our office. Our phone number is 630-381-1381. Or you can email us. And very easy. We'll reply and call back.
Awesome.
It's help@osiclinic.com.
Perfect. I love it. We'll put all that in the show notes for our listeners to check out.
Yeah, and if you guys know where we are located here at Muscle Activation Schaumburg, Dr. Mohan's office is less than 15 minutes away. So he's right next to St. Alexis Medical Center. So if you're local, which a lot of you guys are, that's where he is.
Awesome. Now, Dr. Mohan, is there anything that I haven't asked you that I should have asked you about your area of expertise?
Well, we didn't talk about neck issues, but that's another time for another day.
Okay, yeah. I mean,
I think that's another hour conversation.
I bet that could be a whole podcast in and of itself.
Probably.
So we did lumbar and thoracic, and episode 2 will be with the cervical. So we will definitely get you back on for that.
Perfect.
So the question that we like wrapping up with for all of our guests then is, Dr. Mohan, what is your definition of health?
So that's a good question. And everyone has different health because it's all genetically based, right? And now with all these apps and all these people trying to tell you how to do your health and your lifestyle, most important thing is keep being vigilant and know know that no one is going to be caring about your health more than yourself. And if you're not caring about your own health, then you're going to lose it. Yeah. And that's really the most important key factor.
That's such a great point, because I would say across the board, the people that we come in contact with, you can tell those who for a long time have really cared about their health and for a long time have not cared that much about their health. I mean, it's pretty cut and dry. And to your point is like, if you're not going to care about it for yourself, you're not going to find people that are going to care about it more for you. So, the onus is on you to care about your health, to be proactive with your health or about your health, and making sure that, you can keep living the healthy lifestyle that you want to live and do the things that you want to do. So,
Right.
And we definitely see that a ton here, because with our model of how our business operates, people come to see us very frequently, probably more than they would see a doctor. And, we're not like the solution, but we can help be a guide, and the individuals that understand that say, hey, my health is my responsibility, then they do really well, I think, with people like personal trainers and nutritionists and people that you see on a consistent basis. But the people that are like, I'm going to hire a trainer so that they can take care of my health, or I'm going to hire a doctor so that they can take care of my health, that's when it becomes an issue. So I love, you're the first person that's brought that up, that it's really our own responsibility to take care of our health. And it's a serious responsibility.
Definitely.
Yeah. And all these practitioners, including myself, we're all just team members. Ultimately, at the end of the day, just like Michael Jordan said, he's the one delivering, right? So you're the one having to deliver your own health, right? What you put in your body, how you treat it, how you take care of it, it's all up to you. They can guide you in the steps, and they can be there if you need direction, but otherwise it's really on you.
100%. Absolutely. Well, Dr. Mohan, thank you so much for joining us. Thank you for sharing your expertise, your stories, your experience with us. We really appreciate it. And I know our listeners gained a ton of value from this conversation.
Well, thank you very much for having me on, and hopefully do it again soon.
Absolutely. We'll definitely have to do part 2 for the cervical spine. That'd be a ton of fun. Now, for our listeners, who do you know that needs to hear this episode? Who do you know that is experiencing back issues or some of the issues that Dr. Mohan described? Share this episode with them so they can hear Dr. Mohan's approach to helping people not only address their back issues, but help get them living a healthier life overall. And while you're online, if you wouldn't mind, head on over to iTunes and leave us a rating and review. It helps people who are trying to find podcasts on exercise, who are trying to find podcasts on health, find our podcast. So if you found value in this conversation today, leave us that rating and review and let us know so other people can find it as well. Well, thanks so much for tuning in. We always appreciate it. Have a fantastic week, and we'll talk with you all next week.